Turning a Georgia group practice into an IOP or PHP is not just adding more group sessions. It can move your business into a licensed program model with new rules. The risk: Georgia may analyze a structured program as a regulated drug abuse treatment and education program, not ordinary private practice care. Group practice to IOP or PHP in Georgia. Here's the operator's readiness review: licensing, staffing, location, and payers. We cover the DATEP licensing question, the staffing and clinical leadership gaps, the site review, and Medicaid and commercial payer readiness. An IOP or PHP serves clients who need more structure than weekly therapy, or who are stepping down from a higher level of care. Patients stepping up from individual therapy or stepping down from higher levels of care need structured outpatient support. The practice may be moving from clinician-level outpatient care into a licensed program model with different facility, documentation, payer, and operational expectations. The post is blunt. Small assumptions become launch blockers when licensing, payer, documentation, staffing, and location aren't aligned around the program you intend to operate. Confirm the DATEP threshold with the state and council before you advertise. Marketing first is a regulatory and billing risk. Georgia Medicaid IOP and PHP billing should lead to questions, not reimbursement assumptions, before admissions begin. The post is direct. Generic group practice workflows often break once the business starts behaving like an addiction treatment program. Generic group practice workflows often break once the business starts behaving like an addiction treatment program. The source's own warning. Behave Health's EHR, CRM, and RCM are designed to give the team a system built for addiction treatment workflows rather than generic group practice administration. 4 readiness areas decide whether a Georgia IOP or PHP expansion is realistic, and whether it survives licensing and payer review. Let us walk through all 4. Skip any one of these and a small assumption can become a regulatory or billing problem after you've committed capital. First, resolve the DATEP licensing question before you market the program. As of May 2026, start with Georgia DCH HFR's Drug Treatment Programs page, the official source for DATEP licensing, applications, inspections, and complaints. Review Georgia's rules and regulations for drug abuse treatment and education programs, Chapter 111-8-19, before assuming your group practice model can simply add IOP or PHP. Second, fill the staffing and clinical leadership gaps a program requires. The program has to support level of care decisions, group programming, clinical leadership, documentation standards, discharge planning, payer review, and operational controls. Define population, level of care, clinical scope, payer mix, and supervision. Then validate against DCH HFR expectations, payer contracts, and counsel. Don't copy a checklist. Third, decide whether your current location can actually support a program. Can the site support confidential group programming and longer blocks of care without disrupting existing outpatient therapy or compromising privacy? Map lease, zoning, accessibility, fire safety, and local approval issues against the proposed use before you commit to a launch date or build-out. Fourth, verify payer readiness. Licensing readiness and payer readiness are related but not identical. A practice planning to bill Medicaid should review the GAMIS provider enrollment portal, managed care participation, and service authorization expectations first. Verify provider enrollment, program credentialing, medical necessity criteria, documentation, authorization review, and level of care billing before relying on the revenue model. The post is specific about software. A converting practice should review whether its EHR, CRM, and RCM can handle program-level operations end-to-end. Confirm the stack can handle program-level admissions and group schedules, not just individual clinician calendars. It must support utilization review and authorizations, which group practice workflows rarely manage. And it must carry program-level notes, billing, and reporting for the addiction treatment workflows the business is taking on. Treat licensing and payer work as 2 related but separate tracks, and start both during feasibility planning, not after you've launched. Licensing readiness and payer readiness are related but not identical. A clean license does not by itself produce a working revenue model. Verify whether provider enrollment, contracts, authorization workflow, documentation, and revenue cycle can support IOP or PHP before admissions begin. Behave Health pairs implementation consulting with an EHR, CRM, and RCM designed for addiction treatment operations, so the operating plan and the software match the program. The EHR, CRM, and RCM are designed for addiction treatment workflows, rather than generic group practice administration. Behave Consulting is designed to help operators pressure test the plan before small assumptions become launch blockers. The aim is to align licensing, payer readiness, documentation, staffing, location, and billing around the program you intend to operate. Stop letting small assumptions become launch blockers. Scope your IOP or PHP conversion with a 20-minute demo at behavehealth.com before you market the service. See the EHR, CRM, and RCM built for addiction treatment program operations at behavehealth.com.